One really good questions for Dr. Taddei. Is she on here?
No, she had to leave.
Say that again. For the panel in general, what are some of the symptoms of liver cancer?
Dr. Abou-Alfa, do you want to do that one?
Sure, I take it from the medical oncology standpoint. And no doubt that many times or sometimes patients might not have symptoms and they present only because of some screening process or some other reason why we're doing an evaluation of one kind or the other. But however, some of the classic symptoms, if they were to happen, include pain in the abdomen, especially in the right upper quadrant. In addition to that, patients, if they have any potential discomfort with eating, i.e. they feel fullness very early, can occur as well. And understandably, some of the symptoms I'm going to describe, they really talk about very advanced stages of liver cancer, which, to be fair, we hope we're not there with any of the patients. None of them are ignoring those symptoms. Like if somebody has yellow eyes, dark urine, fluid collection in the belly, like look very pregnant-like belly, swelling the legs, sometimes confusion, spacing out, forgetfulness. These are really more advanced case situation of liver dysfunction, which we hope not we're going to see. If anything, we hope that all the patients will come to the care for liver cancer based on a screening that, as we said, and we are encouraging to make sure people will get.
Very good. We have another question from the audience for Dr. Guy, who mentioned that there were some medications to treat underlying conditions. Is there a liver-specific medication to help slow the progression of cirrhosis?
That is an excellent question. And the scientific community is working very hard on finding a medication that could do that. They are called antifibrotics, so to decrease scarring, but we are not quite there yet, but there are many clinical trials. And so it's really good to continue to ask your doctor about that because I anticipate we will have some soon.
And it's important to treat the underlying liver disease. I think you highlighted that in terms of fatty liver, hepatitis B, hepatitis C. There was a comment and a question from the audience about a cure for hepatitis B.
So I saw that question. Thank you for putting it into the chat. So hepatitis C, as compared to hepatitis B, hepatitis C has a cure. Medications are able to cure hepatitis C, which is an RNA virus. Hepatitis B is a DNA virus. And so we are at present not able to cure hepatitis B because the DNA, as I had mentioned, can get into our cells and then it's harder to actually cure it. For hepatitis B, we have medicines that can control hepatitis B by decreasing and eliminating viral replication of the hepatitis B, therefore eliminating inflammation and scarring. But again, scientific research is really helping us to understand how we might be able to cure hepatitis B in the future. So also something to be kind of keeping tabs on with your physicians because we can't cure hepatitis B yet, but we hope we'll be able to do so in the future.
Thank you. It's nice to hear from Dr. Abou-Alfa that there are so many different treatment options. One question from the audience is, how will treatment affect my daily life? Will I be able to work, exercise, and perform my usual activities?
Oh, thanks so much, Dr. Actually, if anything, I'll tell you, I have a good answer for that one, which is great. Please remember, this is not chemotherapy. These are actually mainly driven by immunotherapy and biologic drugs. And if I were to say jokingly, the best side effect is that I'm really begging patients to come to clinic because they're all busy traveling and vacationing and doing what they like to do. So that's very important to remember that 95% of patients on immunotherapy will not even get any symptoms. It can happen that some of them will have joint pains. They can have some rashes. They can have some diarrhea, but always manageable and will be able, as we heard from Dr. DeRemer, will be able to control those enough that people can have the regular functionality back to where it should be. Some of the biologic drugs can have a little bit of more kind of, how to say, well-stated symptoms like weight loss, and add to this maybe The hands can be affected with some peeling of the skin, but again, usually management. And always, if I were to say anything, please, I urge the patients, don't wait and keep going on a drug. Let's say if it's a pill until you see the doctor, call the doctor, explain to them what's going on. They will be able to help you to really keep the functionality. Because after all, our success in all those cares is making sure that patients are able to lead with their life normally. Otherwise, we really did not do a good job in that regard. And that's why I start by saying, I'm beyond delighted to really be able to see some of the therapies are happening even on every 3 to 4 weeks basis, and patients are able to go on their holidays and be with families in between. So I would say, thankfully, people can have a manageable daily life as if they really don't have the cancer to begin with.
Thank you.
I was going to say to that, the person living in Florida, I think that one of the challenging adverse events for us is particularly the hand-foot syndrome. If you have a patient who's very active and they like to run, it becomes really challenging when they try to mitigate some of the challenges with friction, both on their hands and their feet, particularly their feet in the hot Florida sun. Hand-foot is something that's difficult to deal with, particularly in the South.
And there are strategies for the rash that occurs on the hands and the feet.
Yeah. I mean, there's ways to try to control it, but it is one of the ones as it relates to people who are very active to try to control those symptoms.
For you, Dr. DeRemer, there was a question from the audience about how to sort of keep track. Do you have any advice for patients and family members to keep track of their medications? You had mentioned the immunotherapy cards that you can keep track of the medications you're on. You had mentioned some drug or medication interactions. It's important for patients and families. How do you recommend for your patients to keep track of those?
With some of our younger patients, of course, with some of our younger patients who are more apt to if they want to participate in telemedicine, then oftentimes they're active on their phone and they like some of the apps. There are some compliance apps. So particularly from adherence perspective, there is some nice apps that they can download on their cell phone to basically have some of their data reporting as it relates to their compliance. From the immunotherapy perspective, I know there's some companies that have a tracking of your document or tracking of your adverse events. And I mentioned a couple there on the slide. The one that we used for HOPA, there's some, it's basically a calendar method and you can list your side effects. And if you should start to have an early rash, you can track your thyroid changes. Those are sort of more PDF type documents that they can download and basically create those type things. But I think those type things really help healthcare professionals when they come in. They have particularly as it relates to the hypertension, some of the adverse events we talked about, sort of getting a handle and sort of when these things are occurring in relationship to the treatment.
Very good. Those are helpful tips. And I think we have time for one more question, maybe for Dr. Guy. One individual had a liver transplant in 2020. Prior to transplant, procedures were done to eliminate the tumors. What is the recommendation for surveillance after any treatment? If the patient has liver transplant or local regional therapy, systemic chemotherapy, how are we continuing to do surveillance to follow up after a cancer treatment?
That's a great question. So let's start before transplant. So if a patient, for example, is undergoing local regional therapy with a chemoembolization or an ablation, we often check with a multi-phase CT scan or MRI 4 or 6 weeks later to see if there's been full treatment response. If there's been full treatment response with no active cancer, then we move to an interval of every 3 months, usually for the first 2 years. And thereafter, if there's been no recurrence, we can extend that interval to every 6 months. If, for example, a patient has undergone liver transplant, at our center and many centers, we use something called the retreat score, which is looking at the risk factors for recurrence after transplant, thinking about what was your alpha fetoprotein level at the time of transplant, what did the explant, meaning when we took the liver out and it looked for cancer, was there any active cancer there? If so, were there any high risk features of that? We give people a score, and based on their score of high risk features for recurrence, we determine the interval of surveillance. But in general, oftentimes what we're recommending is for someone who may have some risk factors every 6 months, MRI of the abdomen or CT scan of the abdomen, CT scan of the chest, and alpha fetoprotein. But again, this is something to talk to your transplant program about to say, hey, what was my retreat score? How do I need surveillance? Because there are some people post-transplant who have such a low score that they don't require surveillance.